Dear colleague, welcome. Welcome to this pro-con debate dedicated to the use of ECCO in ARDS patients. There will be two opponents. The first speaker will be Alain, who is one of the leading experts in the use of extracorporeal approaches to ARDS patients. And his opponent will be Giacomo Bellani, who is the leader of the lung safe study recently published, who launched a number of good considerations and opportunities to understand the world of ARDS. Thank you and enjoy the debate.
Hello, everybody. It's a real pleasure for me to discuss with you and with my good friend Giacomo the need for extracorporeal CO2 removal in patients who have ARDS. First, this is my disclosure slide. So why would you use ECCO2R for patients with ARDS? First, these are data that Giacomo Bellani knows very well. Actually, he was the promoter of that lung safe study, which showed that the mortality of patients who have moderate to severe ARDS is still high. 40% for those who have moderate, up to 46% for those who have severe ARDS. So there is room for improvement here. And why actually would you use ECCO2R for these ARDS patients? The rationale is to decrease the intensity of mechanical ventilation. This is here a diagram we published last year in a JAMA review paper summarizing what might be the benefits of decreasing lung stress and strain in these patients by decreasing ventilator-induced lung injury, volutrauma, barotrauma, telectrauma, biotrauma. All this is permitted by the technique using extracorporeal removal of CO2, which allows to decrease the tidal volume, the plateau pressure, the respiratory rate, and also the driving pressure. And the driving pressure actually is central to a lot of discussions over the last 5 years since the publication of this paper by Amato, showing that there might be an exponential increase in the mortality of ARDS patients should the driving pressure goes above 15 centimeters of water. This actually was also confirmed by the lung safe study, which showed that there was a significant difference in mortality, with a higher mortality for those patients who had a driving pressure above that threshold of 14 to 15 centimeters of water. Also, very interesting data coming from the lung safe database about the respiratory rate. This is a second paper from that same study showing that the respiratory rate was independently associated with mortality. And there was actually a major impact here with a 3% increase per additional breaths per minute in ARDS patients. So everything may be integrated in the concept of mechanical power, which in a single formula, in a single parameter, can integrate tidal volume, driving pressure, the flow, the PEEP, and the respiratory rate. It's quite complicated here. But what you have to remember that there might be also a threshold here for the mechanical power above which the mortality increases significantly. And this has been demonstrated here for ECMO. This is a cohort we conducted in a number of large ECMO centers worldwide. And we were able to show that this mechanical power is very elevated here. That's obviously in severe ARDS patients who goes on ECMO, but the strategy of reducing the intensity of mechanical ventilation here permits to divide this mechanical power by almost 4 in these patients. And it's quite similar when looking at data from ECCO2R patients. So what is the evidence now? This technique has been developed for years now, but it's only in the last decade that there was a revival of the study by the appearance of new membrane oxygenator. And it's only in the last 3 or 4 years that there is a lot of activity about that technique, and especially the supernova trial we developed together with the ECMONet and the ISICEM trials group. This was a study which evaluated the feasibility and safety of ECCO2R. This is, as of now, the largest study published on that field. The study included 95 patients. We had 3 devices here, Mackay and Novalung, which were high-flow devices with machines allowing an extracorporeal blood flow between 1 and 1.5 liters per minute. And there was another machine, the Alain device, with a lower flow between 400 and 500 milliliters per minute. In that study, we applied to patients with moderate ARDS a strategy of decreasing the tidal volume, decreasing the PEEP hat. At the same time, there was a small increase, but significant increase in the PEEP, which allowed us to significantly decrease the driving pressure. And this is here the concept, to have lower energy transmitted to the lower part of the lungs. And of course, if you decrease the tidal, if you also, for certain patients, decrease the respiratory rate, you might create artificially respiratory acidosis with an increase in PaCO2 and a decrease in pH. And the interest of that technique is to allow a strict control of PaCO2 and pH. We're not talking about using that technology for patients who have baseline elevated PaCO2. We're talking about patients who had close normal or slightly elevated PaCO2, and for whom we apply this very active decrease in the intensity of mechanical ventilation, and the clearance of the CO2 is permitted by the CO2 removal by the machine. We later reanalyzed a little bit more in detail the result of that study, and we were able to show, which is not novelty, that the higher the flow, the larger the size of the mammary stationator, the higher the efficacy of CO2 extraction, which permitted here more patients to reach target. We had fixed here in the protocol, and it was also possible to have a more significant decrease here in the respiratory rate and a tighter control of the pH. I'm sure Giacomo is going to talk to you about the adverse events and the accidents which may occur with that technique. Of course, it's an invasive technique because you set up an extracorporeal device with blood flow circulating outside the patient. So there may be accidents also linked to the anticoagulation which is used in these patients. And actually in the supernova pilot, up to 40% of the patients had some adverse event, but only 2 had severe adverse event, which may have been related to the technology. And also when looking at the difference between the complication rate between the low flow and the high flow devices, it appeared that it was mainly the low flow devices which had more complications, especially more hemolysis and also more bleeding here. So it's a little bit reassuring if we want to use the machines with the higher extraction flow. So we concluded from that study that it was possible and reasonably safe to use the machine. What should we do now? We should probably try to determine which is the population of interest, and it was the purpose of a second sub-study of the supernova pilot, which showed that alveolar dead space and static compliance were probably the 2 most important parameters here, which were associated with the change in the driving pressure. And we are working now on a kind of algorithm which may allow us to determine which is the population which might benefit the most. And it was also demonstrated that it was only the high flow device in that study which allowed us, especially for those patients with a high dead space, to reach the outcome of interest. And it was also shown that using this type of a strategy, it may be possible to use randomized trials targeting a good population of patients with less patients needed to be screened. So to end up this talk, this first part, we need higher scientific evidence. We only have, for now, pilot data, and this is going to be the purpose of new trials. This is the plan we have now to launch the Supernova randomized trial. Clearly here, I need to mention that this technology is not for patients who have refractory hypoxemia. This is only VV-ECMO, it should be used, but there may be room here for patients with mild to moderate ARDS to reduce the intensity of mechanical ventilation, to limit VILI in and to end up with improved outcome in these patients. Thank you very much.
So good morning to everybody. Thanks a lot for allowing me to present today. It is also my privilege and pleasure to be able to debate with my friend Alain. And first of all, let me tell you that I really honestly greatly admire all the work that Alain and his team have done. I think we all learned a lot. So my talk is not at all contra their work, but it's probably trying to show things on a different perspective. And if I'm able to discuss with you today, it's mostly thanks to Alain's work. So just an introduction in this sense. Okay, my conflicts of interest, which are not really relevant for the present talk. And I think we have, when we speak about ECCO2R, we have to define a little bit the ballpark where we are playing in. In fact, there is no real, I would say, complete separation between ECCO2R and ECMO. We have certain situations in which certainly we have ECCO2R, like a very low blood flow, there is no oxygenation, like 0.3, 0.5 liters per minute. And then as soon as we increase the blood flow, we have a continuum that will bring us to a full-blown ECMO, let's say 4 or 5 liters per minute of extracorporeal blood flow, which is an ECMO, but also as a fringe benefit with ECMO, we always have also the removal of CO2, and so the benefits of lung protective ventilation. So with ECCO2R, we achieve only lung protection, whereas with full-blown ECMO, we achieve lung protection and improvement of the oxygenation for, let's say, refractory hypoxemia or anyway severe hypoxemia. So in a sense, it would make more sense to use ECCO2R as Alain showed in mild to moderate ARDS, where oxygenation is not a huge deal, whereas as soon as the patient becomes more hypoxemic, we move towards ECMO. So why am I con ECCO2 removal in ARDS, not con ECMO? Con ECCO2 removal. The first argument is that, as the Latin said, frustra fit per plura quod potest fieri per pauciora, which basically means it is pointless to do with more what can be done with fewer. And the lung safe data were shown already, but let me point out a few details. The patients were ventilated in the moderate subgroup of ARDS with a tidal volume of 7.6 ml per kilo and the respiratory rate around 20, targeting almost a normocapnia. So what happens if we play a little bit with the ventilator? This is the situation we were starting from, and only bringing the tidal volume to 6 ml per kilo, so decreasing it slightly, with a, let's say, reduced compliance, we would obtain a decrease in driving pressure by 4 centimeters of water with just 6 breaths per minute increase. So there is a large room in our daily clinical practice already to improve the way we ventilate the patients. And also, which is, as I said, a remarkable reduction in driving pressure. And also the fact that clinicians were mostly targeting normocapnia, especially in mild and moderate ARDS, has an important consequence, because I hope we all remember from physiology, because I still love physiology. We know that the determinants of PCO2 are CO2 production and alveolar ventilation, so minute ventilation minus dead space. And we normally see the relation in this way. We can flip it and see what happens to minute ventilation if we accept to increase PCO2 from 40 to 15 millimeters of mercury. We have a further 20% reduction in minute ventilation. Or, and this strategy was proved clinically feasible by a rather, I would say, extreme experiment by Jean-Christophe Richard, where in moderately and severe ARDS, they dropped minute tidal volume from 6 to 4 ml per kilo, showing a dramatic reduction in driving pressure, which was associated with a clinically remarkable increase in PaCO2. As I say, this experiment is a little bit extreme, but still it's an important proof of concept. So essentially, to summarize your point, if you want to reduce the load of ventilation on your patients, what would be your choice? ECCO2R or turning a knob? If you are a lazy doctor like me, then you have your answer. I would rather turn the knob. Second argument, why am I contra this? Is there real a niche, a population of benefits a population of patients who would benefit from this? And I always like to go and watch pro-con debates because you see the same papers shown under a different perspective. And of course, I will show you the supernova, which was a very well conducted study in moderate ARDS. What was the hospital survival of their patients? 62%, which is remarkably similar to lung-safe study, because the amount of mortality that is explained by ventilation, by VILI in ARDS, is only a part of it. And as we will see, the less severe the patient is, the less the mortality is explained by mechanical ventilation. So yes, we may probably reduce mechanical ventilation, but I'm certain we will make an impact on mortality on the less severe patients. And again, you have seen this plot already from Alain, and let's focus on the column with the higher estimated alveolar dead space fraction. Which are the patients who would die more because of ARDS, as shown in a classical study? The higher the dead space, the higher the mortality. In these patients, you will achieve a protective ventilation only if you have a device with a high extraction capability, which means at least 1 liter per minute of blood flow. So in the more severe patients, you will need a higher blood flow, and this can start to become an oxygenation system, because you can calculate it can provide up to a third of the total oxygen consumption of the patient. And again, I'm quoting the words that Alain and the genius man who is Iwan Golliger wrote in conclusion of this paper, which is that the lung protective benefits of ECCO2R increase with higher alveolar dead space, lower respiratory system compliance, and higher device performance. So to me, it looks like as if they are saying you will have to apply this in more severe patients who are more hypoxic, and higher device performance sounds like shifting a little bit from ECCO2R in moderate ARDS to ECMO in severe patients. So to me, this paper shows that the focus should probably be shifted a little bit. And in the last minute, yes, I would like to allude to the complications about, is ECCO2R really safe? Well, first, once again, this I have to congratulate the authors, because they were very honest. They conducted a very well performed study, and they were honest in showing the complications, which Alain mentioned already. The risks of bleeding. 6 patients had a significant bleeding, but I would also like to mention the hemolysis. Those who work with ECMO are always used to have hemolysis. We think it's a complications that we might accept, but oh, sorry, the title is right, but we know that hemoglobin can injure the lung by itself. So these are my conclusions. We have room for major improvements in mechanical ventilation management. I think that less hypoxic patients will unlikely benefit from this technique. And so probably, rather than a real ECCO2R, we might need a mini ECMO that would work in moderate to severe ARDS. Thank you very much for your attention, and thank you, Alain.
I sincerely congratulate the two speakers for the excellent presentations. After all, it's not real a pro-con debate, but just depicting two different visual angle of the same problem. I guess that they make some comment concerning especially the need of having, if possible, a tentative algorithm grading and scaling the intervention RDS, just defining the timing when the ECCO can be used. And I would like to have from them a comment concerning what's happening during these days with the surge of COVID-19, how can be applicable these techniques under these conditions. So I invite Alain to start with these comments, or replica, please.
Thank you very much, Massimo. Actually, yeah, these are one of the main questions. The first is to identify the population of interest. So we don't know really yet what kind of population. Is it mild, moderate, severe? Not for sure the super severe, because those patients, they need ECMO for oxygenation. Then the second question is when. If we look at ECMO data, the sooner the better. It has been demonstrated that if you wait days after the initiation of mechanical ventilation, the outcome of patient who receive ECMO is worse. So it maybe is the same here. There may be a room, let's say, within the first 2 days of the initiation of mechanical ventilation in which the benefit might be the greatest, because it's probably by decreasing the intensity of mechanical ventilation should, and I agree with Giacomo, should this decrease be transduced in a benefit in terms of mortality. It's in that window that maybe the most benefit which might be obtained. And the last point, of course, if we have surges of patients like in a major pandemic, this technology like ECMO cannot be applied to everybody. And at some point we will need to define algorithm criteria also for initiation for sure.
Giacomo, it's your moment.
Yes. Yeah, well, I think in a sense it was a pro-con debate, in that my suggestion would be to basically, in terms of what you say, Massimo, was to optimize the mechanical ventilation, and apply all the adjunctive treatments. And once again, I think that the earlier study had it was great in that all patients positioning and everything. So once all is set up in terms of lung protective ventilation, PEEP titration, blah, 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 at that point, either the patient is okay, or I think you have to go with some form of ECMO. So to me, really the niche of patients in whom you would make a difference with a very low blood flow ECCO2R is quite limited, because once again, these will be the patients, in most cases, these patients will also be hypoxemic. I completely agree with Alain in that during the COVID surge, there was no, I mean, it was really hard to even think of ECMO. I recall the first days, and as you know, Italy was the first country hit in Europe, and colleagues were calling from other institutions saying, oh, do you do a lot of ECMOs? And you're like, guys, the problem here is to ventilate patients, and it's hard to save one patient's life with ECMO, because you are draining a lot of resources out of the other patients. Now that the situation is more stable, and knocking on wood, for time being, we have a reasonable number of patients, then I think it's a form of ARDS, essentially COVID pneumonia, and I think we can apply the same rules that we apply for ARDS also to ECMO.
So thank you both. It means that probably under so-called normal circumstances, even though you may have an increased number of patients with complicated situations like the COVID-19 with pneumonia and ARDS, you may try to apply selecting the patients carefully. But obviously, under the big surge, this is absolutely impossible.
Exactly.
Do you have any other comment each other, or the point
I have
a
bit provocative question for Alain. I want to ask him, not provocative, but as an expert, what is in your unit, what is the lowest blood flow you use for ECCO2R?
So we tested virtually every devices, those devices running at very low flow, let's say between 200 and 400 milliliter per minute, up to a higher flow device, which obviously are ECMO machine, which has been downsized to a blood flow between 1 and 2 liters per minute. The small machine do not allow you to decrease a lot tidal volume and the respiratory rate, because otherwise you will reach a very high PaCO2, does not control the CO2 clearance. Of course, above 1 liter per minute, and with a big oxygenator, it will be possible to clear virtually all the VCO2 of the patient. So you may go very low in terms of respiratory rate and driving pressure and so on. So, but we don't know. We don't know. I agree with you that those machines are echo machines, because to get full oxygenation or decent oxygenation, you definitely need to go to 2.5, maybe 3 liters per minute. So this is real ECMO. In between, that might be called high echo or mini ECMO. It's only here sits on the words we use for these technologies. Going back to the COVID, for now, we need to say that echo should not be applied except in the setting of trials or registry study, because we lack data about the efficacy. It's clearly different for ECMO, big ECMO devices. We have shown recently that we can get very similar outcomes in COVID-19 patients that we got in other types of ARDS. We recently published that the survival rate of those patients is 65% at 2 months. So this is different story here. The problem here, if we have a lot of patients, is to select those patients who can benefit and to get enough rooms, ICU rooms, and also devices to provide the technology to a large population of patients.
Thank you both for the excellent debate that will be for sure very well appreciated by the audience. Thank you. Bye.